other presentation don't have any slides, so I'm fine with just using paper. We've all heard throughout the week about the issue of the 10.6 million children under 5 who die every year. Many of these are from treatable conditions. The main causes of death, as you've heard this morning, from pneumonia at 19%, diarrheal diseases at 17%, neonatal severe infections 10%, malaria 8%, and measles at 4%, HIV/AIDS at 3%. These are all from World Health report from 2005. Of those 10.6 million children who die occurring annually, this is really, in my view, as all of our views, is an unforgivable situation when we can identify the human genome, we can map that, we can cure cancers, we should surely be able to treat these kind of problems. And the main thing here that I'd like to talk about is that many of these children would not die if they had access to the medicines that they need. And children under 15 account for about 1 in 6 HIV/AIDS-related deaths worldwide and 1 in 7 new HIV infections. The vast majority of these are occurring through mother-to-child transmission of the virus, which is something that the UNICEF published in 2005. Due to poverty epidemics, environmental degradation, life expectancy of some of the least developed countries is declining. Shockingly, in some parts of the world, it is as low as 33 to 37 years. Children from a very young age are left to fend for themselves. They're asked to be employed to carry burdens that are way beyond them. And as pediatricians and those who care about children, we all recognize that this is an untenable situation. As an example, in sub-Saharan Africa, there's approximately 9% of children under the age of 15 who have lost at least one parent to HIV/AIDS, and they're left to fend for themselves and obviously take on burdens which they shouldn't be dealing with. Many developing countries cannot rise out of the poverty with their productive populations dying of infectious and now chronic diseases, and many children, as a result, also are dying of these chronic illnesses that they should not be suffering from. The link between the development and health is a very key and intrinsic thing, and it is by looking at the future of societies, that is their children, that we could perhaps hope to assist these children in their quest for a better quality of life and to create a healthier tomorrow for these kids as well as for all of us, and obviously a more secure planet. We've heard throughout the week about the Millennium Development Goals. I'm not going to restate those, but one of the key interventions is to reduce child mortality, and to address the major concerns of the MDGs is to increase access to medicines. This is needed for both adults but also for child diseases, and we need to foster development of child-specific medicines that need to be made. The WHO, UNICEF, and other partners have begun to address this issue, and first we have to the first way we're addressing this is we need to take stock of the situation that we have. So effective interventions exist for many of the conditions that cause child deaths. You've heard about this today. You've heard about it from Trevor earlier in the week, as well as in presentations. Pneumonias, as we've heard, can be treated effectively with appropriate antibiotics. Diarrheal diseases and neonatal sepsis require oral rehydration solutions, zinc, and antibiotics for supportive care, respectively, as we've heard also. Malaria should be treated with a combination products, as well as artemisinin component as part of that combination therapy. HIV requires a package of care, including antiretrovirals and appropriate use of medicines, such as cotrimoxazole, to prevent some of the opportunistic infections that occur. These are just part of the things that we have. All these medicines are classified as essential medicines, and by that I mean they satisfy the priority health needs as we have put forth by the WHO model list on essential medicines. This has been out for, the model list has been out for many years, and I'm going to talk about that in a minute as well. But many of these essential medicines do not exist in the appropriate dosage forms for children. In some cases, oral liquid or syrups are available, for example, in some of the antiretrovirals. But the cost of the syrup is about 2 to 3 times as much as the same dose of the same product that's used for adults, and this is based on the International Price Guide estimates. Obviously, this is one of the challenge. It cannot be provided due to the cost of shipping, or it cannot be provided because of the weight of the syrup, or because some of these are powder preparations that need to be reconstituted, and they require water, and if the water is not safe, you've now subjected the child to another problem. The liquid formulations are generally much less stable than the solid dosage forms, and they may require special storage conditions as well. Sometimes they require refrigeration. If there's no electricity, you have a problem there as well. So from a practical point of view, for diseases requiring treatment with multiple medicines, having a child take 3 tablets or even 2 tablets or several syrups once or twice or 2 or 3 times a day is going to be an untenable situation. For all of us, we realize how hard it is just to get a child who understands all needs and has all the resources available to take a medicine 3 times a day. Can you just imagine when all the other burdens are placed upon them? It's not a realistic approach to enhancing treatment adherence. On top of that, it creates another situation, which is the concern of a rising amount of antimicrobial resistance, which we're hearing about, and is one of the other issues which we're very concerned about at the WHO. In a preliminary survey by WHO of 29 countries, it was found that many of the key medicines for children, including the basic antibiotics and antimalarials, were not available at all. According to the survey, strategies being used by countries to provide medicines for children included using fractions of adult forms or adult preparations, such as a quarter or breaking the tablet in half, using intravenous injections, a liquid preparation, as an oral preparation, which obviously is not an effective way of doing things, and or giving prescriptions of medicines for children from adult preparations by crushing the tablets, breaking in half, or opening a capsule and trying to sort of partition it out for what one would think would be a dose for a child. The problems arising from these approaches include the lack of accurate dosage with potential efficacy problems and safety problems as well as hazards to the child. For example, they're taking inappropriate solid forms, or they're taking medicines which are supposed to be time-released, and they're ending up taking a capsule that is not time-released, but they're taking it all at one time. In addition to that, there's also a problem to healthcare workers, because if you have a preparation that you open, for example, a cytotoxic medication for children with malignant diseases, now the healthcare worker is exposed to chemicals which could be detrimental to their health. So what is the cause of the problem, and what is WHO doing to solve this problem? There are many reasons why medicines for children are unavailable. And really, simply put, the problems are 2 parts. One is there's a market failure system and there's a health system failure. Manufacturers are reluctant to undertake research and development into medicines for children due to the unpredictable and small market size for these products. We understand this is a challenge to them. Therefore, many have not been properly tested in children for efficacy and safety, although, and we are addressing this, and I'll get back to that. Fixed-dose combination products, FDCs, highlight this problem. For some diseases, including malaria, HIV, and tuberculosis, fixed-dose combinations are the recommended treatment, as they reduce the number of tablets patients have to take, which in turn improve adherence to treatment. However, since fixed-dose combinations are not needed in many of them, the more affluent markets, studies on the use of fixed-dose combinations in children haven't been undertaken the way they need to be undertaken. Health system failure is illustrated by the fact that there's a poor supply and poor procurement issues, and many other things, including transparency issues in certain aspects of this problem in many nations. Preliminary data from a WHO study of 14 countries suggests that only half of a sample of about 20 key medicines for children is available in the public sector central stores, and far fewer at primary health care centers. So basically, if the medicines are not there in the public sector, then what is the option? Well, I will explain that you end up having people go to the private sector. One sample study showed that one product out of a list of 20, and the only one, which was the oral rehydration solution, was available. So if it's not available in the public sector, then the only way you're going to get the medicines is for people to turn to the private sector. And the availability there may be better, but the cost may be higher. Not always, but the cost could be higher. That puts another burden on individuals, particularly when the resources aren't available. Individual resources aren't available. Now, despite the initiatives within Europe and North America, many essential medicines for children are likely to remain unavailable unless there's an action led by a public health agency, and that's where the WHO comes into play. So what is WHO doing to try to tackle this problem involves certain aspects. The first is there is a model list of essential medicines that has been an effective tool for prioritizing medicine selection and supply for nearly 30 years. This coming October, that essential medicines list will celebrate its anniversary. It was put into place in 3 developing nations, obviously 30 years ago, and it has grown to 150 countries at this time. And so at least and we know of 150 countries that have their own list of essential medicines. They've adopted the model list to apply to the diseases that are prevalent within their community. In many cases, the national lists are the basis for the national public sector supply of medicines. This year, the WHO obviously is embarking on a model list of essential medicines for children. This is something we decided last year to take on and to figure out how we're going to accomplish this. The model list will provide a framework for identifying the missing priority medicines for children for subsequent research and development, manufacture, pre-qualification, and supply. Obviously, the pre-qualification program is something which we've been doing for HIV/AIDS medicines. It's been in place since the beginning of this century, or decade, we should say, about 2001, and it's been a very effective program. But we also need to move forward in supply, how to get medicines out there. To alleviate child suffering and meet the international development goals, WHO and UNICEF have agreed on a joint strategy and action plan. So what are some of the things we're going to do here? We're going to identify the most needed medicines for children, including supportive evidence on their public health relevance, efficacy, safety, and cost-effectiveness, and we will ensure that the prescribers and patients make sound and cost-effective use of pediatric medicines. We do have many expert committees that address different issues. We have an expert committee on medicines. In 10 days from now, we will be meeting here in Geneva to discuss these medicines for children, to start to identify what are those medicines that need to be moved forward. From there, then we take it to the next step. We'll identify the key R&D, or research and development requirements for producing better medicines for children. We are already discussing and will be working with the governments and the pharmaceutical industry to improve the existing medicines for children, stimulate production and development, and help the governments deliver the medicines to the children who need them most. We have spoken to the civil society, NGO groups who get out there and get the message out there. And we put out a call for companies to submit their child-specific medicines to our pre-qualification program to ensure that they meet the quality, efficacy, and safety standards that already apply to the adult medicines. In May this year, the world gathered together at the World Health Assembly to address this. The WHO executive body is made up, the WHA is made up of the WHO member states, and that comprises 193 countries. And the WHO passed a resolution requesting the governments to encourage the manufacture and licensing of children's medicines and to do research and development of appropriate medicines for diseases that affect children. Obviously, this is the path that we need to move forward through the Executive Board to the World Health Assembly to move any of these programs forward, and this is part of the whole resolution process of how the WHO moves forward. The world is on board, but we must act with urgency on this. To carry out our proposed program, we're calling on all the stakeholders, from the governments, from civil society, industry, NGOs, and everyone, and the academic community, to begin to focus on this crucial and urgent issue. All the players need to work together. We will provide industry with clear information about the most needed medicines, and we hope that the governments will provide incentives to industry to start to develop some of these children's medicines and to help get these medicines where they are needed most at a price that's affordable to poor communities out there. We're asking on everyone to get the message out. This is the title is Make Medicines Child Size. I forgot to stop by the office. I should have brought some of the posters that we're putting forth. And the objectives here are, how do you get all these people involved? So the objectives are to make medicine child size, but how do you get all these people involved? And one of the things that we need to do is to come up with incentives that are out there. One of the possibilities is we said that R&D needs to move forward. It's very hard in some of the challenges that many of these stakeholders face. I've spoken with some of the individuals within industry, and I said, why can't you take, and this is one of the proposals that I had discussed with them, why can't you take some of your profits from other medicines and sort of direct it to an area, whether you create your own foundation for this or you create a certain part of your group to look at medicines for children, and you can underwrite the cost of that R&D by other aspects of products that you make for for both the developed world and for some of the nations that recognize that they need these medicines. For example, medicines that are more for chronic diseases that aren't necessarily, or better yet, I should say, medicines that are more diseases in the industrialized world, but not specifically in the developing world right now, so that you can sort of offset this. This is one of the reasons I raise this is as to whether to create a separate area is something which comes back to the world of critical care. And I realized that when I was practicing critical care, sometimes what you had to do when you wanted to make sure all children were cared for, and sometimes somebody, at least in the nation I came from, didn't have the health insurance that they needed, but it didn't mean you turned that child away. So how does the system survive and keep moving forward, particularly in the economics that we have? Well, you sort of underwrite the cost of that child whose care needs to be provided by sort of other aspects of other things that you were doing. And I realized that was sort of the balance that you had. And I remember this, at least in my world, it's changed now because of pediatric critical care as its own specialty. But when I started, anesthesia and critical care was sort of tied together. In some ways, the anesthesia part of our team would underwrite some of the cost of some of these critical care needs of children, and this is obviously in specific, in one nation. But we have to figure out ways where one part of a system can underwrite the costs of another system. What our objectives are is also to move this forward by getting all the nations to recognize the needs here and to get the message out to their community. What we would like to do is also to get civil society, NGOs to help carry this message. We've been working with a lot of groups on this whole issue. I like to see this where this is as large a, quote, campaign about people recognizing this as many other things that have been out there. We have seen things about cancer, breast cancer, and other health issues that are out there. There's no reason making medicines for children can't be done as well. The other issue that I see is that in effective campaigns, for all of you who travel a lot, there's not an airport you don't go into that you don't see this when you walk into the plane, the posters. I don't want to promote any one group or not, but there's like financial institutions where they have the little posters of effective ad, effective messaging. There's no reason why we shouldn't be able to get this effective messaging out there and then to get people to start to get on board. One of the last things I'd like to talk about is one of the other proposals that we are looking at about getting medicines out there, and this is something which we've addressed with some of the countries in sub-Saharan Africa, and I'd rather, and until we move it further, I'd rather not, mention which countries in particular. But we have spoken to some of the ministries of health about this. About 8 or 10 months ago, I was flying over Europe, and I was looking down. I noticed that there was something which was very unique, and for all of those here from Europe, you will notice that if you look down, you fly over a country, and you see a lot of sort of green grass, and then also there's a community, there's a village, and there's everything centered, and it's centered around, particularly in this part of the world where it goes back into the 14th century and 15th century, it's centered around a church and then the community around there. And I was asking myself, why is it that that's how it was all set up? And I said, because at that time, in many centuries ago, the religious community was the center of that community, so everything got built around there. So I was saying, why can't you build a similar system in developing world by you make a center around somewhere? And the reason it was the center in Europe, the religious community, was because that's where you went for advice, information, even for health information, because the options in the 14th, 15th century weren't there for what we have today. And I said, why can't you come up with a system where people gravitate to one area for health? And I know we have a lot of clinics. And then when we were in sub-Saharan Africa, one of my directors and myself, I said, we have a situation where there are all of these shipping containers that come in. And I knew this when I was driving back and forth in the U.S. between Washington and New York, and you drive up the Jersey Turnpike, and you see New Jersey Turnpike, see all these shipping containers been sitting there. And for years I drove back and forth. I said, those are probably the same shipping containers from 5 years ago. To take those and to paint them and make them into a color and get the community involved, make it some unique color, and then get the talent of a community, and I've seen the talent of individuals in parts of the world to actually do the artistry, the craftsmanship, and to create containers and to set up and make a pharmacy, make that shipping container into a place that actually ends up being a place where people know that that same colored container, that shipping container, actually is the place you go for safe medicines, for health information about these issues. And then if an individual moves from one community to another community, they know to look for that shipping container. Just like what ended up developing in Europe, you develop a community around this one area, and you target people to help be part of this whole process. And I believe that by pulling people together in a situation like that, you can end up making individuals recognize that this is where we go for health information. This is where we go for the medicines that are safe, because there's a major problem about safe medicines that are out there right now, and then move it from one place to another. What we are doing is we've spoken to some ministries of health about this to see if we can get people to utilize a concept like this and move it from one area to another. This will give them an opportunity to actually be part of the process to improve the problem and move it from there. There are many other things I would like to talk about, although I'd rather open up to questions to you about some of the things we're using with technology to advance these missions as well. I think to close, the main message is that we do have the science, we do have the technology and the financial means to get almost a third of humanity a better life and a better chance at getting medicines. And I think that this all begins with improving the life of children. If we don't solve this problem, if we don't make kids healthier today, then this whole problem that we have right now in the world is just going to repeat itself in the next generation and the generation to come. So somewhere we have to break that vicious cycle that's going around. It's almost like one of these little loops, a pain loop that you have to break it at some point so that you can start fresh and make a resolution to this problem. I thank you for listening. I'd be happy to answer any questions about our medicines program, technologies program, or some of the intellectual property issues, or what I've spoken about.